She needs no introduction. She is a very famous consultant in IVF. But just to introduce Dr. Monica, she is a MD from the prestigious PGH and the Chandigarh Institute, and she did her senior residency from AIMS, New Delhi. She's a medical director of Sadbhavna Women, Sadbhavna IVF, Sadbhavna IVF School, as well as Sadbhavna IVF, Sadbhavna Medical and Heart in Patiala. She has been in practice for almost 27 years now. She's the chairperson of Academic Committee and former Secretary Patiala Obs and Gynae Society. She's a member of IFS, Joint Secretary also. And she has various presentations to her credit. Chiefly among, she has presented for 6 years in a row at the prestigious ASHRAE conference, as well as she has also presented at IFFS conference held in New Delhi. And she is part of the reviewers list for ASHRAE 2019 and 2020 for the guidelines for good lab practices, good ultrasound practices in ART, OPU. And she has a dedicated IVF skill lab, which is first time in the region for north of India. And she has that in particular. She trains people. With this, I end my presentation. Thank you so much. You can contact us on the fertilisacademy.com or email us on the fertilisacademy@gmail.com. You can also note down the phone numbers. If you visit the website, you can all get all the contact details. Thank you so much. And over to you, Dr. Monica, for a very insightful session on chronic endometritis. Over to you, ma'am.
Thank you. Thank you so much, Dr. Sarpreet, for your generous words. And thank you personally for in my capacity that whatever I have on my CV is all because of it's your contribution to make it all possible for me. So before we start, it's difficult times for us over here. As you all know what's going on. So we had a discussion whether to continue with this. So Dr. Sarpreet, we were deciding whether to continue with this program as our minds are with our defense forces. They are at the border. A lot of tensions in this place. Our prayers are there. But we thought as it's pre-decided, we'll just go ahead with the talk today. So chronic endometritis is something I'll be talking about chronic endometritis, excluding tuberculosis. Now, excluding tuberculosis, regarding chronic endometritis, a lot of literature has been published. But how do we translate that into our clinical practice points? Do we have evidence to diagnose chronic endometritis? Do we have evidence to treat it? And what is the outcome for the patient? So for all this, one second. You can see the screen.
And the screen is visible.
Rashmi, one second. This is the one. Yeah. So if there's any problem, if I'm not audible, please interrupt in between.
Your voice is absolutely clear, as well as the screen is nicely visible.
Okay, thank you so much, Dr. Sarpreet. So we'll be discussing the specific parts of chronic endometritis as it's relevant to our daily practice. Specifically in the context of the etiology of chronic endometritis, its relationship with reproductive outcomes. How do we diagnose it? What is the normal uterine flora? When we say that it is a bacterial infection, then we have to know what is the normal uterine flora and what is considered as an infective flora for us. What are the treatment options? And does treatment improve reproductive outcome? What is the evidence for it? And finally, what are the clinical practice points and how are we going to treat our patients in the context of all this? So chronic endometritis is considered a localized infection or an inflammation of the endometrial mucosa, characterized by there are a few pathological findings which include increased stromal cell density, the presence of edema, specifically in the proliferative phase, and a dissociated maturation between the glands and the stroma. But the hallmark to define or to diagnose chronic endometritis is the presence of plasma cells in the endometrial stroma. What exactly are the plasma cells? I'll be taking it up later. Now, an infectious etiology has been presumed. Why? Because it has been seen an increased incidence in pelvic inflammatory disease. Bacterial species have been identified. Endometrial cultures were positive in around 73% of the patients compared to 6% of the control. Further, if antibiotics have been seen to treat it, that is, after giving a course of antibiotics and then repeating an endometrial biopsy, 80% the cultures were negative compared to 5% in the controls. And still further, clinical outcomes were improved with a course of antibiotics. So these all points are in a favor that it has an infectious etiology. So when we say infectious, then which bacteria? Then the second question, the main question that comes to your mind, that what is a normal bacteria in the endometrial cavity? Only if we know the normal bacteria, then only we'll be able to say that this is a pathological bacteria and this needs to be treated. So initially, culturing the bacteria, it was presumed that the endometrial cavity is sterile. That was a few years back. But now with NGS for our RNA sequencing technique, it has been seen that the normal uterus is not sterile. There is a low but active biomass. This is around 100 to 10,000 times less than what's seen in the vaginal flora. The question comes, is this biomass stable? That is, if we detect the biomass on day 5 of a cycle or day 14 or day 25 or after sexual intercourse or after an oral contraceptive pill, will the biomass be the same or there is a differentiation? Vaginal contamination while sampling is one major issue for defining the exact uterine flora. And further, when we are doing an NGS sequencing or when we are doing an RT-PCR, we have to amplify because the flora is so less in the normal endometrial cavity. To get a significant flora to identifying, these cycles have to be run like which we had in COVID, the COVID cycles to detect the virus. So similar is the case with the detecting the bacteria in the uterine biopsy. So recurrent cycles, repeated cycles have to be run. Because of which, whatever contamination is there, little contamination is there through the vaginal flora, that gets amplified and that gets dominated because even a little bit of contamination because of the repeated cycle. So this is a major issue while doing endometrial biopsy and studying the flora is the vaginal contamination and the amplification of the vaginal contamination. Further studies done in normal population are very few. They are like in double-digit numbers. And another issue is that when we are doing detecting the flora by sequencing techniques, it is fragments of DNA, not viable DNA. It is just that the bacteria was once there. The significance of it at that particular moment is not defined. The various bacteria which have been presumed in a normal, which have been studied, which have been seen in the normal uterine flora are these various groups, out of which to generalize, they have said that lactobacillus is a very prominent component in most of the studies. So, but how long does this microbiota remain stable? We don't know. Like how many samples do we have to take? Do we need 3 samples? Do we need a sample on day 5? One in the proliferative phase and one in the secretory phase to average out that this is the flora? We don't know about that. Then lactobacillus, though in most of the studies, it is the prominent flora. But when samples have been taken in cases of uterine hysterectomy, which have been done abdominal, and the samples have been taken by cutting open the fundus, in those cases, the presence of lactobacillus was much less than compared to that where the vaginal samples were taken. And then secondly, it doesn't make sense when we talk of lactobacillus in the uterus because we know that the embryo is cultured in a media of around 7.3 in the IVF lab. That is the ideal pH for the media. Lactobacillus grows in an acidic pH, that is a pH less than 4. So that doesn't match. So there is a link which we may be missing. The lactobacillus could be there because of contamination. It could be there that when we say a good lactobacillus leads to a good outcome, it could be that a good lactobacillus in the vagina also leads to a good outcome. So it could be a extension of the vaginal flora. So as of now, we don't know exactly how to define the uterine flora, but whatever studies are done, they're all towards this, that lactobacillus is the predominant flora, and wherever lactobacillus is there, the outcomes for whether it's infertility or ART, the outcomes are better. The bacteria which have been studied and the most common infectious agents responsible for chronic endometritis are, we have these Enterococcus faecalis, then the Enterobacteriaceae, which would include Proteus, Klebsiella, Pseudomonas. Streptostaph are a very predominant species which have been identified. Then comes Mycoplasma and Ureaplasma. Chlamydia and Neisseria have been significantly low in all studies whichever have documented the infectious agents in chronic endometritis. It has been around 2%. Rest, the predominant are Staph, Strepto, Enterococcus, and Enterobacteriaceae, Mycoplasma, and Ureaplasma. A possible now what happens with the microbial infection? A possible microbial infection of the endometrial cavity or dysbiosis would induce pro-inflammatory molecules, triggering unusual immune responses in the human endometrium. And so these changes could affect endometrial receptivity. It can lead to decreased success rates for both spontaneous and ART conception, as well as even contributing to obstetrical and neonatal complications, which would include placental deciduitis. There is a growing body of evidence, but not universally accepted, that chronic endometritis worsens the prognosis in cases of unexplained infertility, recurrent pregnancy loss, and recurrent implantation failure. The evidence is more in favor of recurrent pregnancy loss. Now, it is often asymptomatic. Maybe in around 20% of the cases, there may be non-specific symptoms, in the sense there may be some dyspareunia, pelvic pain, a vaginal discharge, irregular bleeding, or some mild GI discomfort, but on the whole, it is asymptomatic. In a general population, it has been seen to be around incidence are up to 19%. Infertility, the incidence reported is up to around 40% in different studies, and further higher it goes in recurrent implantation failure and recurrent pregnancy loss, even up to 60% it has been reported. And it is more common when there is a structural pathology in the endometrial cavity, especially polyps, submucous fibroids, and any retained products of an incomplete abortion. So having said all this, how do we diagnose chronic endometritis? We don't have the symptoms. By history, we may not. Ultrasound is, it gives us an idea when we see the endometrium, how the pattern of endometrium, whether it is smooth or whether there is more of echogenicity, it is irregular. Or in the secretory phase, you have a little like a loose type of endometrium, or a very thick, even a very thick endometrium in the secretory phase is also a pointer to infectious. It could be an infectious pathology. Then the gold standard is to do a hysteroscopy to diagnose it. After doing a hysteroscopy, we need to take an endometrial biopsy and can do a histopathological examination and diagnose plasma cells, which are be taken as a hallmark for diagnosing chronic endometritis. Plasma cells can be identified by H&E staining or by a surface protein marker CD138, also called Syndican-1. Also, we can have a bacterial cultures or do an RT-PCR to identify the organism causing the etiology. So regarding hysteroscopy, what are the pointers? Hysteroscopy, there was a workshop done in 2019 and they concluded that the hyperemia, focal, diffuse, hemorrhagic spots, or edema of the in the proliferative phase, or micropolyps less than 1 mm, they are all pointers towards that this could be a case of chronic endometritis. Hysteroscopy can be an overdiagnosis also, but micropolyps are more specific than and specifically if you have more than one, finding, it is more specific. But there could be an overdiagnosis, and in the studies, it was seen that up to 98% of the patients, I'll be just quoting this study, up to 96% of the patients who were studied for a diagnosis of chronic endometritis in the infertile range, 96% had some findings, specifically hyperemia, diffuse hemorrhagic spots. So hysteroscopy it can lead to overdiagnosis, plus there's a subjective variation to it. The findings, as you can see over here, this is the hemorrhagic hyperemia that occurs. This is the stromal edema. Then you may have some punctate hemorrhagic spots, which are focal. Then these are the micropolyps, which can be easily seen when fluid goes in the uterine cavity. Even if you do it in the proliferative phase or the secretory phase, they stand out clearly. So the diagnostic accuracy in itself for hysteroscopy is modest because it leads to a lot of overdiagnosis. But if it is negative, then one can be assured that, okay, this case, it has a very less chance of having chronic endometritis. It is a subjective diagnosis. More specific is with micropolyposis. And most importantly, it gives an idea for the site of endometrial biopsy, because chronic endometritis is not a diffuse lesion. These are skip lesions. So if you just do a blind endometrial biopsy, you can tend to miss out the area which is suspected of chronic endometritis. So now what about the endometrial biopsy? Now this is since 1907, like I myself, this was like something new for me, that since 1907, this is a statement that we are inclined to make the detection of plasma cells as a diagnostic criteria for chronic endometritis. Now, plasma cells, at one go, one wonders what are these plasma cells, because somehow what we read in MBBS, it's like at the back door. We don't. Well, I'll just relate to you with update to you. What are these plasma cells? Plasma cells are a type of white blood cells and are an important part of the immune system. They develop from the B lymphocytes and they produce antibodies. So now this is the B lymphocyte. Wherever there is infection, we have these B lymphocytes, especially in the mucosa of the gut and in other near the tonsils, like as lymphocytic aggregates. So whenever there's an infection, the B lymphocytes, in the presence of infection, transforms into plasma cells, and the plasma cells are the antibody secreting cells. So in the endometrial cavity, the B lymphocytes are less than 1% in the endometrial stroma. They are in the basal layer of the endometrium. This is the functional layer which gets shed off, and this is the basal layer. So it is over here. Over here, you can see these B cells, the green colored B cells. They are normally present less than 2% of the total cell and less than 1% of the total lymphocytes in the endometrium. When there is any infection, these B lymphocytes, they transform into plasma cells. The plasma cells shift into the stratum functionalis over here, and they produce antibodies. And because of these and the cytokines and the hypersecretion of the antibodies, it affects the endometrial implantation. So when there is infection, the B lymphocytes, they extravasate, more of them get incorporated in the endometrial from the blood vessels, and more of it changes into the plasma cells. Now, one thing to note over here is that normally we have a few B lymphocytes lying at this junction. So if we take an endometrial biopsy at the time just after the menstrual period, that is when the endometrium is thin, at its thinnest, so one can get a little deep bite of the stratum bizalis and one may see normal plasma cells over here. So specifically for chronic endometritis, it is visible to do the endometrial biopsy late into the proliferative phase or near the late secretory phase, so that we do not get the normal plasma cells, a few plasma cells, which could be scattered in the stratum bizalis. The plasma cell has a very typical picture, eccentric nucleus. But to identify plasma cell in the tissue section is difficult because the endometrium is a cell-dense structure. And there are skip lesions. You might have a plasma cell here, you might have a plasma cell at the other end of the biopsy. So it is a very time-consuming process. So to find a way out is by using this immunostaining, that is by CD138, which is a specific marker of plasma cell and has been shown to increase the success rate of accurate diagnosis. This is a protein surface marker CD138 on a plasma cell. And after staining, you get brown spots. So this just at one look, one can see, okay, these are the CD138 positive cells. And so it is presumed that these would be the plasma cell. Though with CD138, there are certain issues of false positive. There could be some lab errors also in it. There are certain epithelial glandular cells which may have a surface marking for CD138. So to be very accurate, it is also proposed that wherever you have these CD138 cells, the pathologist can concentrate on this area to identify plasma cell on H&E staining. But most of the studies which are there, they just quote plasma cells as being the brown spots as we see with the immunohistochemistry. Another marker which is coming up is the multiple myeloma oncogene 1. This is a nuclear marker for plasma cells, but as of now, it is under research. As of now, its role for identifying plasma cells in studies is not standardized. What we have in literature is using CD138. So once we have these number of plasma cells, how many plasma cells do we take as normal, or how many plasma cells do we take as abnormal? There is no consensus. There are around 100. If each paper has its own definition, there is nothing standardized. Some say that even a single plasma cell is significant. Some say that it should be around 1 to 3, take it as 1 to 3. Some say 5 to 10. So there is a variation. There is no consensus. There is no guideline from any society. But most of it is like up to 1 to 5 plasma cells are taken as abnormal. The more the number, the more is the significance of it. Then this has to be, as these are skip lesions, they have to at least, they say, count 10 high power fields. It's just not a single high power field, but to see 1 plasma cell per 10 high power fields. If it is present, it is taken as significant. Then the question comes, can plasma cells alone be used for clinical decisions, or do we need a history, or do we need a background of the patient, or do we need to have something positive in the RT-PCR? Or do we need some pathological changes like a stromal edema or a mismatch between the gland pathology and the stromal pathology, or just a CD138 positive means chronic endometritis? So to highlight this was a paper presented at last ASHRAE. Dana McQueen, their group, they have done a work on plasma cells in recurrent pregnancy loss patients. So what they found that if they just took 1 or more plasma cells per 10 high power field, the controls it was positive in around 31% of the controls and 56% of the patients with RPL. But when they added endometrial stromal cell changes, then it was found that not a single control was positive, and in RPL, the positive rate was 30%. So they proposed that chronic endometritis be defined as the presence of one or more plasma cells per 10 high power fields in the setting of endometrial stromal changes. But this has been discussed, and there were comments on this study. And as of now, because there is no consensus on what are the stromal changes that we are going to document, so as of now, to diagnose chronic endometritis, one is just taking the number of plasma cells 1 to 5 per 10 high power field. Then comes when we say it's an infectious etiology, do we need to diagnose the bacteria over there, or we leave it at that? Bacterial cultures are difficult because the bacteria we know are difficult to culture, and it takes a long time and it's expensive. So RT-PCR has come to our rescue. RT-PCR gives us an idea of the bacteria, and then we can give targeted antibiotic therapy. Of course, false positive due to contamination has to be kept in mind. Now, this is a very good paper. Like, if you're interested, it gives a comparative study of histology, microbial cultures, hysteroscopy, and molecular biology for the diagnosis of chronic endometritis in infertile asymptomatic. So the most common infectious agents which they had studied in this paper, which I'm just quoting, and after this, all the studies have related to these organisms. And over here in India, the ones which we have over here, the platform which we are using also has these all of these by RT-PCR. Enterococcus, Enterobacteriaceae, Strepto, Staph, Mycouria, Chlamydia, and Neisseria. These are the ones which we have with us to diagnose. Now, in this, it was 60 to 96%, as I said, positive findings are there whenever we see for infertile patients because hyperemia is so common. But there is a stronger correlation with micropolyps. And the significance would be, if it is negative, then about less than 5% are CD138 positive. Now, is there a correlation between CD138 and finding bacteria? Logically, there should be, like the bacteria should be there, and then only that induces these plasma cells to form from the B cells. But it has been seen that if CD138 is positive, RT-PCR was able to detect an organism in around 30 to 40% of the patients. Broadly, there's a different percentages given in different papers, but this is the broadly, just to sum it up. And if RT-PCR is positive, then CD138 was also positive, and again, around 1/3 of the patients. So now coming to treatment, how do we treat this? There is limited data. Broad spectrum antibiotics are the conventional treatment. Overall cure rate in literature has been around 60 to 100%, but the endpoint of cure is different in each paper. Some say an endpoint is you repeat a hysteroscopy and see that the findings are okay. Some say you repeat an endometrial biopsy and see that the CD138 levels have decreased. And the third is that to see whether the RT-PCR, the cultures are sterile regarding the pathology which we had seen earlier. So again, there is no consensus on that. The antibiotics recommended first line, of course, is doxycycline 100 milligram twice daily for 14 days, normally which we give for our infertile patients normally. Is doxycycline 100 BD on the first day, then 100 OD for the next 8 days or so. This is a normal doxycycline regime for patients. But specifically for chronic endometritis, it is 100 milligram twice daily for 14 days, and it was seen to cure around 2/3 of the patient. Cure meant a repeat endometrial biopsy and doing the RT-PCR. Then a second line of drug, if specifically if there's mycoplasma or ureaplasma, a second line of drugs with, like, if doxycycline, as I said, it treats in 66% of the patient. Then the second line, which has been studied, is adding a quinoline, levoflox, cipro, uflox, OD or BD doses for 14 days, combined with a metrogyl or tinidazole for 14 days. This was seen that if we use doxycycline, only the cure rate was around 2/3 of the patients, and those which were not cured, in the remaining 1/3, either levo, cipro, or uflox was added along with an anaerobic cover with metro or tinidazole, and that led to a further cure of around 20%. Now, specifically, if there is ureaplasma or mycoplasma, as recommended by CDC, the treatment is first 14 days of doxycycline, and second 14 days is moxifloxacin 400 milligram OD. This is specifically for myco and ureaplasma. In studies where after using doxy and levo and metro, still the pathology remained, the third line drug recommended was amoxicillin and cloveline. It can be considered as a third line. Or we can simply go according to the bacteria isolate. So as I said, test for cure is different in the different studies quoted. There could be an improvement in hysteroscopic findings. It could be a decrease in the number of plasma cells. It could be absent plasma cells, or it could be an RT-PCR negative. So what does the evidence say? The evidence is this is a systematic review and meta-analysis. It showed that women who did not have chronic endometritis have better reproductive outcomes, like better rates of live birth and clinical pregnancy. What else do we have? This is for recurrent reproductive failure. This is a recent one, 2024. It showed an association of chronic endometritis to infertility and recurrent pregnancy loss, while no significant association was noted in case of recurrent implantation failure. Again, another review article, again showing a better prognosis after treated with antibiotics. This is an article which I had shared in the group. It's just a recent one, worth reading. You can go through it. It just sums up the whole hysteroscopic diagnosis and management of endometritis. So now coming to our IVF patients, do we need to screen before all IVF patients before doing an IVF cycle? Does the diagnosis treatment have an impact on IVF success rates? Now, as of now, we need this answer. I think this is the most important question, and we need to decide in our clinical practice that do we need to screen patients before our IVF, because it is such a simple thing to treat. On one hand, we are saying that chronic endometritis treatment can lead to improved failure. So do we need to screen it before all IVF patients? There is no definite, robust published data. So if we had a consensus for screening hysteroscopy in the first place, we would be automatically diagnosing chronic endometritis before doing IVF. So what is this consensus? Initially, a few years back, even like 2 years back, we had the INSIGHT and TROPHY studies, which did not give us a consensus for screening hysteroscopy before IVF for all patients. But now, this is upcoming evidence 2024, outpatient hysteroscopy impact on subsequent assisted reproductive technology. The conclusion was that office hysteroscopy may enhance live birth and clinical pregnancy rates in infertile women undergoing ART, even when previous imaging studies show no apparent intrauterine lesion. Then we have this just recently published this year, the pivotal role of hysteroscopy in diagnosing subtle uterine lesions in infertile patients. Seeing the unseen can make the difference. So we have more and more evidence coming up that yes, a screening hysteroscopy could make a difference. Now, what do the guidelines say? For recurrent implantation failure, out of the few things which can be recommended is, this is a yellow light we have over here, that is, it can be done. That is, assessment for chronic endometritis can be considered. If chronic endometritis is diagnosed, treatment with antibiotics can be considered. So I think this is a very good proof for from the ASHRAE guideline group that in cases of recurrent implantation failure, this can be considered. So do we wait for a patient to have recurrent implantation? Or this is a very good viewpoint. It's a very nice article, or just 2 pages. One should go through it. That when should assisted reproductive technology workups be performed? Should we do a tiered approach, or should we do all on day one? Specifically, things which are not going to change, like if you have an organic pathology, we should be diagnosing it at the upfront rather than waiting for her to have a failed IVF cycle. Now, there is more and more evidence which has come up in the last 2 years. This is a very famous work of Lugano workshop on recurrent implantation failure. And this is a very famous, a very good study, 2021 and 2024. What they have emphasized is that when they have done 3 to 5 euploid frozen embryo transfer cycles, around 95% of the patients conceive. That is, before doing a cycle, if you rule out the gross organic pathology, like if you do a hysteroscopy, a 3D ultrasound, but you rule out uterine pathology, and of course the other regular things which we do, then only 2 to 5% of the patients did not conceive after 3 to 5 euploid frozen embryo transfer cycles. So recommended to conduct all necessary assessments upfront rather than following a tiered approach. The initial evaluation should strive to capture all persistent conditions that would lead to failed implantation. Now, on the other hand, this was 2023. Should we stop screening for chronic endometritis? Their argument is that a substantial delay in this would lead to a substantial delay in the initiation of subsequent reproductive treatments. It could there could be a disruption of healthy uterine bacterial microbiomes with blind cumulative antibiotic use. There could be antibiotic resistance, additional expenses. The complications associated with the invasive nature of endometrial biopsy and hysteroscopy should not be neglected. So this was a review article to sum up regarding the management of chronic endometritis. This is last year, 2024. What was their suggestions? They recommended screening patients at risk, not all patients, but those at risk for chronic endometritis with endometrial biopsy during the late follicular phase or early luteal phase. They recommended treatment for greater than 3 plasma cells or greater than 2 per 10 high power fields on the biopsy with doxycycline, followed by a test of cure, that is by repeating an endometrial biopsy. And if the plasma cell numbers was less than 2, that is 1 to 2 per 10 high power field, then one to decide on a case-to-case basis. So this is all the evidence what's there in literature, which I could sum up. Now, having seen that and having heard that, what should be our practice points? Like, what should we do? This is what I could think of that it should be done. You may not agree with it, but you can just think about it and formulate your own clinical practice points. How do you intend to treat your patient? One could, patients for IVF who have suggestive features. Suggestive features mean there is something like a history that it could suggest an infection, or there's something on the ultrasound or the endometrial pattern which could suggest an infection, or if there's a hysteroscopic finding which suggests an infection, a failed IVF cycle, a recurrent implantation failure, RCL. Yes, these are definitely the ones which need to be tested for chronic endometritis. But other than that, We can also do it at the outset as a screening hysteroscopy, and rather than following a tired approach. We at our center do hysteroscopy for all our patients for infertility and IVF. I think in a private sector, the expense is not there. The expenses is up to us that how much are we going to charge. But if you go into corporate hospitals, it becomes very expensive for the patient. But it makes things very simple. And once you start doing it yourself for all patients, you will not need evidence for anything to be proven. The things there, they just glare in front of you that yes, a screening hysteroscopy is helpful. It really shows a lot. So how to diagnose? We diagnose it by hysteroscopic features, as I said. Then you do an endometrial biopsy, specifically in the late follicular or early secretory phase. Do CD138 staining, 1 to 5 per 10 high power fluids or greater. More than 1 is more significant. If you have less than 2, it is for you to decide whether this patient needs antibiotics. Then the features on the histopathological, whether there are any other changes like stromal edema or mismatch of the endometrial and stromal gland. And then do an RT-PCR along with it. If an RT-PCR is positive, then treat according to the bacteria, or if the suppose RT-PCR is not positive and you just have a CD138, then simply you can give doxycycline BD for 14 days and followed one course with a levoflox or uflox and metrogyl, or specifically according to the RT-PCR report. Questionable is the role of repeat biopsy. Questionable is the role of probiotics, but somehow it makes sense, though we don't have evidence that when we are giving so many antibiotics to add on probiotics for that 1 month of antibiotics. Role of intrauterine antibiotics, there are case reports where they have given intrauterine antibiotics to the extent, one thing it's reported every 3rd day for 1 month. There is one paper, then there's one paper which has just given it twice. So there's nothing standardized. These are just case reports given. Role of this marker is more specific and more studies are coming up. As of now, we are with CD138 only. This is our data regarding our chronic endometritis. So if a patient had an IVF failure or there were hysteroscopy, specifically micropolyps, then we have been sending it for the chronic endometritis panel. 69 endometrial biopsies we have studied. Out of that, 26% were positive for an organism. And out of this, all in the 18, all were positive for mycoplasma and ureaplasma, except 2 which had E. coli. So over here, the samples which we had were around 90% predominantly mycoplasma and ureaplasma. And as I said, mycourea needs specifically to be treated by moxifloxacin as the guidelines by CDC. Out of these 69 patients, 37 patients were also positive for CD138. 4 patients were positive. The 2 patients had hydrosalpinx. So this came to an incidence of 11%. But there was no correlation between a patient positive for RT-PCR and CD138. This correlation was not there. So what we do, if we just have CD138, we give them just a course of doxycycline. If you have an organism, then doxycycline and levoflox. So it depends on a patient to patient how to decide. But one thing must be kept in mind that inadvertent use of antibiotics may be more harmful to the normal flora. Exactly the role of chronic endometritis, we cannot say, yes, this is there and this is harmful, and giving antibiotics are not going to be harmful. So one should be very specific, do a hysteroscopy, decide where you want to use antibiotics, and are you convinced that antibiotics need to be used? That is your decision. As of now, whatever the evidence with this, I've shared with you. And so thank you so much. And it will be nice to share with you your experiences or questions, whatever you have for chronic endometritis. You have questions, you can put them in the chat box or ask them as such.
We do for this recurrent implantation failures, we used to give treatment called like torch treatment. The first half of the cycle, we used to give doxycycline and metrogyl, and the second half, spy along with some probiotic, spiromycin.
Yeah, so this is what's there. Like instead of giving it to all patients, then maybe we could identify a group by doing the hysteroscopy and have more objective evidence. Yes, but that is it is so right.
Yeah.
We are all used to giving doxycycline to all our patients, so it's just that now maybe we have to limit that doxycycline and decide. So we are not there yet. What's going to work best for which patient? But role of antibiotics, we have all seen, yes, that it is there for patients who are not conceiving.
Maybe CRP also gives an indirect indication, madam, that there is some endometritis. Like, not a direct, I mean, it's not a direct marker, but indirect.
The evidence is not there yet as of now for PRP. So, but case reports are there. People are using everything. So, but the evidence is not there to be used. Maybe if you have a very thin endometrium, it's like on the thickness, thin of endometrium, maybe those are the cases where PRP might be helping. So,
yes, madam, like correlating it with the scan findings.
Yes, definitely. Thank you.
Thank you.
Ma'am, there is a question in the group, in the chat box. Dr. Sirisha is asking, can you repeat in which phase of menstrual cycle biopsy is to be taken?
It's preferred in the late proliferative or early secretive. That would be somewhere around day 9 to day 13 over there. Because if we go earlier, then the basal endometrium, we might get a plasma cell from the basal endometrium, and you get a high positivity rate with CD138. So somewhere later in the cycle and not premenstrual, in the mid-cycle somewhere is the best time to get in. Day 10, day 11 would be a good option. There's a question whether we can use steroids. Steroids have been used, progesterone also, but like we don't have that evidence. But in papers, prednisolone and steroids of people are using it, but we don't know how it's going to help us or not. And it's like steroids being anti-inflammatory, and when we want an endometrial implantation, we need that inflammatory aspect also to remain. So steroids may not be able to use it in it without solid evidence. But case reports are there. Maybe after a few months, we have studies going up with proving that steroids might help or progesterones might help. But as of now, we don't have that literature to support it. Everything has, even people have tried using DEXA as an injection with ciproflox, intrauterine flushing of the endometrial cavity. So one can try, but we won't know what's helping and what's not helping. And is it? I think whenever we are doing something with the endometrium, we must have a little bit of more solid evidence that we are doing less harm to it than, if not benefit, at least the harm should not be there. So if you're going to do an intrauterine thing, putting it could be harmful also. So I think one has to play on the safer side and seeing what's there, whatever the evidence is there. So thank you so much. So it's nice to be with all of you to discuss these things, and one gets wiser even while preparing the talk. One gets used, so much comes up so fast that If you have to give the same talk after 3 months, there are so much new things coming up. So it's nice to go through it, and by discussing it, things get more clearer. So anybody else would like to add what they are doing? How are you doing a screening hysteroscopy? How many are you doing a screening hysteroscopy before IVF? Or how many you are convinced to do it?
There are a few more questions coming up. What is the first-line treatment? Dr. Austin is asking, what is the first-line treatment in totality?
It would be doxycycline 100 milligram BD for 14 days. And if you think that the patient has, like, if it's CD138 positive also, and you have something on the RT-PCR, or it's a previous IVF failure, or there's an endometritis, like there's something pointing towards it, then first 14 days is doxycycline in the first cycle. Then in the next cycle, in the first half, one must give quinoline, which would be levoflox or uflox, combined with, again for 14 days, combined with metrogel or tinidazole. Tinidazole 1 gram OD for 14 days, or metrogel 500 BD, or what we have over here is 400 milligram BD for 14 days. This is a standard treatment. If mycoplasma is there, then doxycycline for the first 14 days, and in the next cycle, in the first half, give moxifloxacin with an anaerobic cover instead of levoflox or ofloxacin. And sometimes we get E. coli or we get staph and strepto. Then you can add doxycycline with amoxicillin and flovinic acid.
Does intralipid have any positive impact?
No evidence. We don't
Dr.
know
Oko is
that
asking.
role. We don't know for intralipid for chronic endometritis. Nothing has been specified. As such, intralipid for recurrent implantation failure, recurrent pregnancy loss, also we don't know yet. The evidence is not there, so can't say, can't comment on it for its role.
Dr. Kadinga is asking, in case of chronic tuberculous endometritis, how many months of ATT treatment should be given before embryo transfer?
It's minimum 6 months. It comes between 6 to 9 months, depending on the profile of the patient, but it's 6 months, yes, definitely. She might conceive by herself also if her tubes are okay, or there's something, not an irreversible damage to her fertility potential. Then sometimes they conceive after taking the treatment of tuberculosis also.
Dr. Preeti is asking, can you explain about MUM1?
MUM1 is a marker which is a nuclear marker, like CD138. Syndican is a surface marker. So, and there are other epithelial cells which they can also be detected by CD138 as a false positive for plasma cells. So MUM1 is a nuclear marker. So it is more specific. So that is why people are coming up that CD138 has some lab issues also. It could be false positive, and even some cervical cells normally have a stain with CD138. And when we are taking an endometrial biopsy, we could scrape a cervical cells also. So keeping that in mind, to be more specific, MUM1 has been added in literature. There are studies coming up. MUM1 alone, MUM1 compared to CD138, we might be wiser a few months from now what's to be used. But as of now, it's CD138. But MUM1 is more specific. I don't know the cost, how much the cost changes while adding MUM1, can't say. But I don't even know if it's available for us to get it done. But it's a nuclear marker, so it should be good.
Okay.
Any more questions?
I'll request Dr. Meena to and ask. Dr. Meena has some comments and some questions. Dr. Meena, can you unmute, or shall I read out the...
Hello, good evening, sir. Good evening, Dr. Sabjit. Good evening, Monica.
Dr. Meena, it's a pleasure
Excellent
to
talk,
have
very
you.
nice as always.
Yeah.
So informative as always. I would just like that after your conference, I was also wiser, and then the DICE, the live cell company, I got a test done from them, and it was a beautiful reporting. Very about tuberculosis, like we had the dilemma, no, that these guys never give the report. They always give negative histopathology, negative tuberculosis, and we are unable to start the treatment. But these guys were very accurate, and they told us about, I think, around 21 pathogens: the staph, the Klebsiella, uh, everything, like so many of them, like Neisseria and so many others, very clearly, a 3-page report. And I was really happy. That was all because of your conference that we could send the sample to DICE
We had
Life
very
Cell.
nice
Thank
inputs
you.
from you. We had very nice inputs from you at the conference also, Dr. Meena. It's always a pleasure to hear and share with you.
Thank you. Thank you so much.
So there's a question that is MUM1 different from MUM1 is a marker like CD. If we have to take an endometrial biopsy and then stain it with MUM1, it's an immunohistochemistry stain. So like we do a 138 on the endometrial biopsy. So similar is MUM1 on the nuclear cells of the plasma cells. Then yes, there's a very Dr. Sirisha, any effect if we start doxy pre-hysteroscopy? For hysteroscopy, one thing, whenever we are doing it for IVF or chronic endometritis in mind, we should do it like through the cervix, put a speculum and do it, and not do it through the fluid, like through the vagina, which goes because that's going to lead to a lot of contamination in the vaginal fluid going in the endometrial cavity. So it has to be done like not the hysteroscope touching the vagina anywhere, and put a speculum and make it go through directly to the cervix. For hysteroscopy, we in generally give like a simple antibiotic to prevent infection, and like a cefixime, that would be good enough. But once a report of chronic endometritis comes, then we start with specifically doxycycline or not. Otherwise, our protocol is we give them cefixime to prevent infection because of the process of hysteroscopy. So I think so. And then doxycycline, if it is positive, otherwise we don't give, but one could start doxycycline before also. Francis. Thank you, Dr. Srisha. How do you give this doxycycline before hysteroscopy? What's your take on it? Then we have Dr. Austin. Are there any common risk side effects associated with IVF? So one gets pregnant, that's one side effect, and it's a good side effect. So if it's done judiciously with good drugs and a good protocol, the side effects are minimized, and one gets pregnant. So I think it's a blessing for infertile patients and for the doctors both. So I think so that's all for now, Dr. Sarpreet. Any more questions? I don't see any. Do you?
Questions? Can you let me just check the chat box once more? I think there's another question. Has anyone used subendometrial stem cell therapy for NCE, chronic endometritis? Yeah.
Chronic endometritis, these stem cells, PRP, GCSF, they are like just case reports and often non-recommended. So I cannot talk about it as such specifically for chronic endometritis. What is there is antibiotics, what is mentioned. When we talk about these PRP and stem cells, we are talking about a very thin endometrium, which could be Asherman's because of tuberculosis, which is structurally deformed. So that is a patient where stem cells are being tried or PRP because of their growth factor. But an endometrium damaged because of chronic endometritis, but chronic endometritis per se is treated with antibiotics if we have a good endometrium structure on ultrasound. I think we have this class on a course on immunological aspects, and in that class, all these intralipid, PRP, and stem cells are discussed in the course whenever we have it.
Yeah, the course is available on You can visit the app and subscribe to the course.
Also, all that it's a good review course on all these things which are like available but with no evidence, and where we can see which patient needs to can benefit from these treatments, empirical treatments.
Absolutely.
So
So again,
one thing we
ma'am,
had, it is just a few days back, ASHRAE has updated its guidelines on ovarian stimulation. The previous ones were 2019, and now it's just that a draft has come, though they haven't published it. So the draft is there. That was just few days back. So it was very nice going through it. And in the course, we'll be discussing, a lot has come up in the new guidelines regarding how to go about ovarian stimulation in IVF. So that's one good aspect of it, that before the course, we just got these new guidelines.
that's very interesting. So in the end, I would just like to, ma'am, can you just give a bird's eye view of the course so that it becomes easy for them to join?
So it's for somebody who is doing IVF, or somebody who wants to start IVF, or somebody who's already doing IVF. We are going to discuss the practical aspects. It's something that it helps, like when there are so many questions in your mind, there are so many practical aspects, and I think our platform will be there where you can ask all whatever you have in mind, your queries, and we'll be trying to solve them all when you're doing IVF. So whether it's a practical aspect or the lab aspect, so it makes things very simpler, because you cannot get everything in literature or on any one. This is a one platform where once IVF, whether it's the clinical aspect of the patient or the lab aspect. So we are there with you, and the best part is we have these. It's a direct interactive course where you can ask questions, and you can ask questions later on. It's spread out over 2 months. So at your pace, then you can go through the course, because we have recordings available for 2 months. So you can go through them, and then at the end of the course, we'll be having a question and answer review, just to see that where we are regarding the course. Otherwise, we've framed it to keeping in mind all the practical aspects and what needs to be done, or what troubles you while you're doing IVF. So I think it will be a great help for people who are even planning to do it, doing it. And even those who are doing it, we have many detailed aspects of it. So we'll be happy to share our knowledge and experiences and with you on this. So the course is spread out from 28th May to 9th July. The registrations are there till 15th May. So most welcome, and we look forward to your active, interactive participation in the course. Thank you.
Yeah, thank you so much, ma'am. The course is available on the website. You can go and register yourself for the course, and we'll be more than happy to have you. And looking forward to a wonderful interaction. We've got a couple of more demo classes left, which we'll be announcing very soon. And thank you so much, Dr. Monica, for that wonderful lecture. Thank you so much, ma'am.
Thank you so much to all of you. It was nice to be with you. Thank you.
Thank you. We are ending the meeting now. Thank you. Good night. Ma'am, I think you will.
You have to do it. Yeah, I'll do it.
I'm ending the meeting now.